This webinar will concern itself with the clinical identification of dizziness and its likely etiology, particularly as it pertains to serious conditions. It is for PTs involved in treating orthopedic patients, as it's not meant to turn them into vestibular therapists, but simply to know what to refer out and what may safely be treated. We usually come into contact with dizziness in our neck patients, and we tend to immediately assume that it's caused by vertebral artery injury. This is rarely the case, but it's a good thought to keep in mind. I hope that this webinar will enable you to feel comfortable recognizing patients who have benign dizziness and treating them. At the same time, you need to be able to appropriately refer out those you need to. This is the best definition that I know of. It does have its weaknesses, as you will see, but they are semantic rather than pragmatic. Of course, we have to complicate it, and the next few slides will do that quite nicely. For the most part, orthopedic therapists' concerns with dizziness is whether or not it's being caused because the vertebral artery has been injured. And this is, of course, a genuine concern, regardless of what treatment you are planning. Directly or indirectly, any treatment that increases range of motion or decreases pain is potentially liable to release an embolus, as rare as this event might be. So this webinar will look at how neurological dizziness might be differentiated from peripheral. In a subsequent webinar, we will look at how the combination of dizziness, headache and neck pain and the patient's history of these symptoms can be analysed to determine how safe it is to carry out movement tests such as declines and even just range of motion. But for now, this will be a short introduction to dizziness differentiation into peripheral and central dizziness. The classification of dizziness is usually given in textbooks as central or peripheral, but these are etiological statements and cannot be made directly from the patient simply saying they feel dizzy. A preliminary step must be taken using the patient's symptoms, so a symptomatic classification. The patient will complain of one of three states: an hallucination of movement, type 1, either vertigo or oscillopsia. Type 2 is a feeling that a faint is coming on, and type 3, the patient actually loses balance. With some thought, you will see that the last is not a sense of disequilibrium, but is actually disequilibrium. And this is the weakness of the definition I gave earlier on. We'll live with that though. Etiologically, dizziness is either caused by neurological problems or non-neurological problems. This is the classification of dizziness, but let's move on to more definitions. Vertigo and oscillopsia are hallucinations of motion. Vertigo is a spinning movement, usually around a vertical axis when upright or coronal when laying supine. It can also be described to occur about a sagittal axis, which is rarer and more often related to more serious disease states such as cerebellopontine tumours or Arnold-Chiari malformations. It is best not to mess with this spin, but refer it out immediately regardless of whether there are neurological signs or symptoms. Oscillopsia is a swaying, bobbing, jumping visual hallucination and is caused by multiple conditions including labyrinthopathies, multiple sclerosis, meningitis, stroke, head injury, tumour, etc. It is not commonly met by physiotherapists and should probably be handled by referral rather than trying to figure out what's happening. Disequilibrium is balance loss, and occurs with severe vertigo, and so may be neurophysiological rather than neurological. But if it occurs in isolation, assume that it is neurological and refer it out. Type 2 dizziness, pre-syncope dizziness, is the most difficult to differentiate, but is usually benign, but it is the type of dizziness that you as an orthopedic therapist are likely to spend most time with. Central undifferentiated dizziness can be caused by neurological or neurovascular disorders, while peripheral dizziness can result from labyrinthine, vestibular neuropathy, cervical dysfunction, visual disorders, medication, concussions, migraine, dietary issues, overindulgence in various comestibles, including alcohol, drugs, too much chocolate, and for me, vegetables. Vertigo is more definite in its symptom, and so it's easier to determine if it is central or peripheral. The direction of spin with peripheral vertigo is consistent. It does not change direction either during or between attacks, while the spin of central vertigo may change direction. Peripheral vertigo is non-persistent, while central vertigo lasts for varying periods after the trigger has gone. Labyrinthine vertigo may include involvement of the vestibular component, and so hearing may be affected, whereas this would rarely be the case with non-labyrinthine or central or other peripheral causes. On the other hand, there is a good chance that neurological vertigo will be accompanied by neurological symptoms, and a better chance that there will be signs if the cranial nerves are actually tested. Nystagmus is a common accompanier of vertigo, either for neurological or neurophysiological reasons. If the cause of the nystagmus is peripheral, it tends to mimic the behavior of the vertigo, non-persistent and consistent in direction. It is also gaze suppressed, so that when you are testing tracking, the nystagmus is actually diminished or abolished, while it is accentuated with central causes. In addition, the nystagmus of peripheral vertigo is curvilinear, usually with the curve being downwards, while it may be purely linear with central vertigo. As an aside, if you ever see pure downbeat nystagmus, it is almost invariably caused by serious diseases. Type 2 dizziness is much more difficult to differentiate into peripheral and central because the symptoms are much vaguer than they are with vertigo. In fact, pretty much anything the patient states as dizziness is dizziness. This could include lightheadedness, nausea, vomiting, giddiness, wooziness, floating feelings, etc. The terms also vary by culture and nationality. You will get different terms from a British person than you will from an American. I would be very suspicious if the dizziness failed to improve within 15 minutes of onset, and this period should be used to carry out a cranial nerve exam. If signs or symptoms are forthcoming, the patient should be referred to the ER. Nystagmus with type 2 dizziness cannot be ascribed to a screwed up vestibular ocular reflex, but must be neurological regardless of its characteristics. And if the dizziness is coupled with a headache, particularly if both are decoupled from neck pain, then I would avoid testing the neck for range of movement or anything that includes trying to provoke the dizziness with neck movements. These would be the issues with dizziness that would most concern me. All of these are reasons for referring the patient to an MD, but some need to go to the ER. These include the following: 1 through 7, and I've put them in red, and the others should be referred to the GP, providing they can be seen immediately by him or her, and that there was no trauma or progressive headache. If any of these are present, then send them to the ER. Causes of central dizziness include some very nasty conditions, including but not limited to VBI and intracranial bleeds. The sooner you refer these out, the sooner the diagnosis can be made and the sooner effective and appropriate treatment applied. If you can do a cranial nerve exam while the patient is dizzy, you are more likely to find signs than if the exam is done when no dizziness is present. However, with severe or moderate vertigo, the patient may be in too much distress for you to be able to complete the exam. In this case, wait until the vertigo passes and carry out during the type 2 dizziness phase if possible. You don't get too many opportunities to do great harm or even kill the patient. Don't let this be one of them. This is a decision tree based on the history and cranial nerve exam. I really don't have anything to add to it, so I'm going to let this run for longer than usual, and of course you can find it in the resource material as a PDF of the presentation. It's not as complicated as it looks.